Good afternoon. It's been a long time. I haven't done one of these in a while. However, I find myself with this young gentleman in the beautiful city of Cordoba at the GCOP-SEOC meeting, which is the surgical oncology meeting in Spain. And I'm here today with Assistant Professor Dr. Juan José Segura Sampedro from La Paz Hospital in Spain, who is a surgical oncologist.
Yes, I am.
With a great interest in research and innovation as well.
Yeah.
So we'll have a little chat in the way these things sort of go. We're in a cafe, which I thought was quiet, but we will manage as we go through. How have you found the meeting, Juan José? How's the meeting been so far?
Thank you, guys, for having me.
No problem.
I've been really interested in the meeting. We've been talking about ovarian cancer, colorectal cancer, pseudomyxoma. I think it's really nice to have once a year the opportunity to talk with other surgeons and check which is the most innovative way of speaking our patient.
What have you seen that's new?
Well, we've been talking about the last techniques, randomized clinical trial, which is about immunotherapy and metastatic colorectal cancer. We've been talking a lot about the IPEC-T4, which is the clinical trial that we did.
We are very involved in this, of course, yes.
And we've been talking too about the possibilities of new clinical trials, which combined the results of Foxtrot and IPEC-T4. Yeah.
Okay, we will see how we go forward. As we were discussing earlier, Spain is a great home of extra treatments around surgical oncology. HIPEC has been a mainstay here for many years. HIPAC also, and all of these augmentative treatments to the surgical aspect. The UK is much more, we'll say conservative. Some may say worse words than this. How long have you been working in surgical oncology?
I've been working in surgical oncology since 2015. And I've been seeing the development of IPEC, there's new IPEC, the new techniques, how some indications grew and now are decreasing. Well, it's a world which is changed a lot with dominant.
Well, what little bit of surgical oncology I did 100 years ago back in London, we took colons out and did colostomies, and that was about it. And the world has moved on greatly. And we'll come back to surgical oncology, but as always with these podcasts, it's around the research and the innovation that is the real interest. You were telling me a little bit about your research topics. Just give us a brief overview of what you're doing on research.
Well, although I started my career as a trauma surgeon and did some innovations and patents on trauma surgery. Right now, we are working really 2 or 3 fields of surgical oncology. We are developing organoids for ovarian cancer to predict chemotherapy for our cancer. We are trying to look for alternatives to HIPEC or IPEC. One of them is an hydrogel which will release the chemotherapy within long periods.
Where are you with that? We discussed that a little bit, and you're doing some terrible things to mice.
Yeah.
Give me a little bit more around that, because I can understand that I'm a failed orthopedic surgeon by training, and so there has always been thoughts of putting hydrogel in knees after you've done arthroscopies, and for that to elute hyaluronic acid or some other magic substance to try and mend cartilage. I think I can understand it in surgical oncology, but tell me a little bit about that. What do you know?
One of the main criticisms for HIPEC that people in this kind of procedures of intraperitoneal chemotherapy is that you can't expect big results with only one cycle.
100%.
Yeah. So now what we are working is how can we augment the deployment of the chemotherapy intraperitoneal, because we've seen that systemic chemo is not as effective for peritoneal metastasis as it can be for pulmonary or for liver metastasis. So what we are trying to do is sometimes in feature relative surgery, one of the main problems is you can't achieve an R0 surgery, and you need to leave some disease behind. Or if you get to remove all the tumor, you are worried about that kind of cells that you try to remove with high tech, but there's always a chance of relapse.
And the one-shot approach, we're coming at it from another angle as Combat Medical, but it's we have a urology business where they face some of the same challenges that surgical oncologists do, that they know that the transurethral section of the bladder tumor has been incomplete either due to the challenges of endoscopy or due to not being able to see the carcinoma in situ. So they know they've missed something, but they have the luxury of being able to give 6, 8, 10 new treatments. In our data, we can show the fairly simple fact that more is better. If you give maintenance treatment in hypothermic bladder treatments, you get a 20% increase on disease-free survival. It seems perfectly reasonable to expect that if you give more drug over a longer period of time, perhaps you cause more side effects, but you certainly have a greater cytostatic effect.
Yeah.
And where are you with it today? First in animal, first in human, first in mouse?
Well, we started with the in vitro experiments. We've been working with paclitaxel, calixatin, olaparib to achieve a controller release, because if you are going to leave that behind inside the body, you need to be sure you are not going to release it all at once. Yeah, that's the main adverse event we could have.
Technology let us down for a minute. We were just talking about terrible things to mice and drug elution. So tell us a little bit about how you're progressing from in vitro, in vivo, small animal, large animal, and when are we going to see it on the shelf?
Okay. Well, I hope we could see it soon, but it's not going to happen. So we are working. We've been through the in vitro phase. We've been working on how to release the drug. We've been working with olaparib, oxaliplatin, and paclitaxel. And it seems we already have the way to have a controller release. And now we are moving to mice. We are starting our ovarian model because we are using immunofluorescence to avoid to sacrifice too many mice. And
it's only mice. That's a terrible thing to say.
Yeah, but it's easier because you don't need to kill the mice to check how the tumor is developing, because you already have a lot of imaging workup. Yeah. And right now we are placing the hydrogel, and we are controlling the adverse events. We are doing like hematologic stuff. We are checking the tissues, and checking if it works, and checking if the cytostatic, the chemotherapy, is going well with those.
When do you expect to publish your small animal?
We are working. We have sent some papers about the models and papers about the in vitro phase already. They are not published yet. And we hope we can finish the mice part during this year.
Okay, so maybe at this meeting next year, you might have some information for us. You might stand up and speak a little bit next year on it.
Yes.
That would be very interesting. Okay, I'll be mean to you now just for a minute then. Why are you doing that? Why are you not just doing NIPEC instead? NIPEC is the future. This is, of course, completely unrelated to the fact that Combat Medical are developing an NIPEC system. But that's another way of doing it. Our urology friends give multiple treatments. It seems very sensible that the surgical oncologist should give multiple treatments. Do you see a role for a more traditional leave the drains in, give some more intraperitoneal chemotherapy over 6 weeks, 6 months or something? Or is that too injurious to the patient?
This has been performed before, and the ethics trials have good results, but the problem is the patient didn't tolerate it very well, and many patients didn't finish all the cycles. So the truth is, although there are some evidence for that, the whole surgical community has moved on, and it's working more in high tech. And we have had some patients that we can reoperate and give another cycle of heartbeat, and that happens. But I don't think we have got the device or the Optimus device for doing that.
Yeah, that's more. Hopefully, that's what will pay my mortgage. That our heat control and flow control is much better than some of the more Heath Robinson, there's a good English phrase, homemade devices that have been tried in the past, and it will be a better tolerated treatment. And also the catheter side of it is very interesting as well, because if you're going to leave an indwelling catheter in somebody for 3 months and expect to get good flow and outflow,
We got many problems with that. The sort of obstructs.
we have developed a novel material of catheter with the guys from the University of Nottingham that has some special properties that so far in our large animal studies show that this will be, I won't say it won't be a problem, but it'll be less of a problem. So watch this space on that one. Everything comes back to regulatory, unfortunately, or perhaps as a check and balance. So it won't be quick. We are probably 3-4 years away, as I suspect you are with your hydrogels. But hopefully this will give an option for patients who, when I would have seen in surgical oncology 30 years ago, we would have done some form of palliative treatment and sent away to the surgical oncologists or to the palliative care team. So we move forward, hopefully. Okay. Just for ovarian, or are you in some other spaces as well? I know you've done some work in liver in the past.
Yeah, in the first time, I was really into the trauma surgery, and we developed surgical device for liver trauma. This was because when I was working in Mallorca, we had a lot of trauma during the summer because the population of Mallorca gets twice larger.
Yeah, as I spend my life sailing around the world, I apologise for the British behaviour. It's not me, but yeah, we do have in Mallorca. I can imagine there's the odd traumatic incident with the viscera. Okay, so how did you have a gel? How did you stop people bleeding to death from their hepatic injuries?
Yeah, well, for a surgery like me and many others, a liver which is broken and bleeding is one of the worst neglects that you can have, because you don't have many ways to control it. And right now, you only place data around and cross your finger and stop it. Wait till it stop bleeding. So we developed like a plastic bag. There's vacuum to the liver, so it stick it together, so it stop bleeding. And one of the main problems with the classical technique is you can lose some grapes inside the patient, and that's
what all surgeries is the ability to counter 5. Yes, when you're making sure you get all of your drapes back out again. That's right.
Yeah. In the trauma operating room, it's bleeding. You just start putting aside the drapes, and sometimes it is a mess.
Yes.
And one of the problems with this technique too is you can put too many drapes and compress the stuff around the liver. So this was a device which gives you exactly the pressure you want around the liver. We tried it. We got the patent. We tried it in things. We did some studies, and it seems it worked. What you were talking before about regulatory, it seems regulatory kills killing that project. To be honest,
and with the MDD-MDR transition at the moment, there's an awful lot of focus, certainly from an industry point of view and an innovation point of view on regulatory. I was heavily involved in the pelvic mesh business, having been the international guy for a company who sold a lot of pelvic mesh before they were banned by everybody. So I'm aware that it's a very necessary area. But it does impact on innovation. Now, we should not all be making things in our garages and taking them into the operating theatre. It still happens. But I do wonder if we have got a little too far.
Yeah, it seems sometimes like a pendulum. Sometimes we are too open, and there is, if you are too open, there might be some people that are doing the wrong thing, but you got to close the circulatory, you are going to discourage innovation. You are going to make people go away. You are going to leave the innovation to other countries.
We should be careful in what we say, because the business, I won't say exactly which hospital room, but the business here for HIPEC was done for many, many years with a cardiac pump and some tubing that was amended in the garage of the perfusionist. So it happens. It happens. But yes, it is an issue around the pace of regulatory compared with the desired pace of innovation. Yes. Perhaps it's an appropriate check and balance, but I wonder if we've gone too far. Okay, fine. I will give you, because I have it as my gift, £1 billion of research funding now. I think I have it in euros. There you go. What are you spending it on?
To be honest, I would hate to spend it in regulatory. But
if you could open a new notified body, that would be the way forward. That's great, Jeff.
I would like it, because I think the trauma device we developed in REIT will have set the same nights.
Yes. But and had multiple uses as well.
Yeah.
Just think of other things, whether it's cardiac temper, there's something else.
You think about liver, but in the surgical oncology wise, I would keep working on this, not only hydrogels, but other forms of controlled release. I would try other drugs in HIPEC with uses for trying all the hydrogel, or not only hydrogel, but other drug release systems. I would try other chemotherapy with HIPEC, because we are attached to oxaliplatin, mitomycin, and 12 more, but there are plenty of space. Immunotherapy could be used for intraperitoneal.
Even the urologists, and I need to be careful what I say, because some of my best friends are urologists. Even the urologists are thinking of using different drugs there now, because you guys are pretty broad in the drugs used, and that conversations the medical oncologists will have about drug choice in HIPEC, which I don't understand. But the urologists, they use mitomycin, and the crazy ones use epirubicin, and that's it. But they're starting there to think that gemdosing might be a way forward. And I think we know in urology that there are BCG-resistant patients. We know in surgical oncology there are platinum-resistant patients. So if there are platinum-resistant patients, then there'll be mitomycin-resistant patients, there'll be gemcitabine-resistant patients. So why not try 2-3 different, whether it's HIPEC or NIPEC or PIPAC, or some form of eluting device to give the patients the best chance. Because if you hit on the drug that happens to be the kryptonite for that particular oncologic cell, curative.
Yeah, I agree totally, because the targeted therapy, the tailored treatment, I think it's not the future, it's now. I think in HIPEC community or the surgical oncology community, we don't have too much money for clinical trials. If we had the possibility to try all the drugs, try all the chemotherapy, immunotherapy, all intraperitoneally, would probably make us advance, give more steps faster than we are doing right now.
I think so. Good. It's good to see that. Is that innovation, or is that just trying everything? And I think that sometimes we don't try everything before we try and invent the next new thing. Okay, another one of my classic questions from this. I will throw you the keys to the DeLorean, and you will go back to the future 50 years. So it's now 2070. What does your operating theatre look like? Is there anybody there?
In surgical oncology, we do have a really wide jail. But peritoneal carcinomatosis, you have too many diseases, too many places where the tumor can be hidden. Laparoscopy is starting right now in peritoneal carcinomatosis. Not many of us are sure about it.
Well, we've submitted in this unit here. We've done some lap HIPEC in the past. Well, for the patient, it's better, I'm sure. For limited recurrences, when you are truly sure that it is limited, it's current. I always say the same, that it's like peeing through a keyhole into a teacup. It's clever, but should you be doing it? T0, R0 is your first aim.
Yeah.
And with my simple surgical background, the best way to do that's through a big hole.
Yeah. In open surgery, sometimes you have been performing the surgery like 8 hours. And when you are about to close, you discover some tiny tumor you didn't see, because you can't see it touch it, but you don't see it. And if you go to laparoscopy or to robotic surgery where you don't have the touching, the feeling, there is a big chance you are going to leave behind some lesions.
It might be that the Da Vinci need to make even more money with their 10th generation robot that not only has tactile feedback but has some form of haptic sense in it as well. Maybe that's that. Maybe that's
Yeah, but the haptic system that are right now, I'm not very good. I think it might go probably if we can develop during these decades some kind of immunofluorescence which aims at tumor, so you can see it through the.
Yeah, recently urology world with some of the augmented visualization techniques of narrowband and Hexvix. Are they used? Yes. Are they gold standard? I don't know.
Yeah, the big problem is you have a disease like peritoneal carcinomatosis, which is we know you can't see it properly in the CT scan.
Yeah.
So how can you use CT scan to do augmented reality?
Yeah. Yeah.
It's hard.
Maybe we talked about this in spinal surgery 20 years ago, and I met a crazy German inventor somewhere that claimed to have something that you would put on your endoscope and would show nerve in one color, muscle in another color, something else in another color, and you just resect the blue bits.
Yeah,
we never quite got there. I don't know. Perhaps he's still
anatomy. That's the dream.
Perhaps he's still in the laboratory or somewhere developing it. But okay, that's fine. Okay, well, thank you very much. I must tease you a little bit about one thing. I gave you a full academic and professional title, but I quite missed a bit off. I missed off. Segura Sampedro, MBE. Now, I mean, surely my ennoblement in the UK is in the post, but you've already had your trip to the palace. What's that all about?
That was a surprise. I just when I was in Mallorca, I was, as I said, working in trauma surgery. And when I arrived there, I saw a lot of tourist people having trauma. So when I went to the numbers, I checked out that there was always tourists. And I started to check for the nationality. And I have to say that British people and Irish people were the ones that suffered that more trauma. So I went to visit the consuls of the consulate of Ireland, because I thought United Kingdom. I went to Germany, I went to France, England, and I don't remember how many times. But I have to say the consul of United Kingdom in the end was really, really interested in how to avoid this kind of trauma, because they have a big population of expatriates there.
The Brexit was that was their decision. They thought we better leave Europe than if we were just fighting with beer bottles on the streets of Mallorca. Goodness! And through this, your work was recognised.
Yeah, and we started working together. We started sharing data. We started doing some prevention campaigns in the United Kingdom and in Mallorca. And after some years, they came up with that. One day I received the call from the ambassador, and I didn't know. I have to say, I didn't know what
is that?
Was
even meant to.
But it was something really nice, because although I have the title, it's something like I think it's for on the health system of Mallorca.
I think you're allowed to graze your sheep on London Bridge now, I think, or something like that. But that's wonderful. That's the work that you've done because of drunken British behaviour. That's right. I love it. Thank you very much. I know it's a pleasure to speak to you. Enjoy the rest of the night.
Thank you very much, guys. A pleasure.